Imagine being a world-class musician, and suddenly your hand no longer obeys you. The fingers that once moved with perfect precision now curl involuntarily, get stuck on keys, or jerk away from the instrument entirely. For performers who develop focal hand dystonia, it's not just a medical mystery. It's the potential end of a career, an identity, a life's work. My guest today is Dr. Nancy Bill, professor and chair emeritus at UC San Francisco, and one of the pioneering researchers who helped transform our understanding of focal dystonia from a mysterious psychological condition to a trainable brain disorder. Dr. Bill holds a PhD in special education from UC Berkeley and San Francisco State University, a master's in public health from UC Berkeley, and a bachelor's in science in physical therapy from UC San Francisco. Her groundbreaking research with neuroscientist Michael Merzenich demonstrated that focal dystonia involves actual remapping of the sensory cortex, and crucially, that this remapping can be reversed through targeted behavioral retraining. Dr. Bill's clinical and research interests span neuroplasticity, repetitive strain injuries, rehabilitation robotics, and intense dual-task aerobic exercise for neurological and degenerative conditions. Most importantly, Dr. Bill was my program chair at UC San Francisco and has been my professional mentor and dear friend for nearly 40 years. In this conversation, we explore the science behind how repetitive fine motor tasks can literally smudge the brain's sensory map, why perfectionism and type A personalities are risk factors, and how creating foreign environments and novel sensory inputs can help the brain relearn coordinated movement. We discuss why education and belief in neuroplasticity are essential to recovery, and the hope that exists for those willing to commit to retraining. Welcome to the Live Aligned podcast. I'm Dr. Brent, a doctor of physical therapy, professor, founder of Polestar Pilates, and pathokinesiologist. For over 35 years, I've been fascinated by the dynamic relationship between movement and pathology. On this podcast, I'll host special guests and friends who are making meaningful contributions to help us live aligned and be kind. Hiking, golfing, running a marathon, or playing with your family. What activity do you want to improve this year? Simply changing your center of gravity can improve your ability to jump or to run. Learning to listen to your internal feedback can drastically improve your game and reduce risk of injury. These are examples of movement integration, which is the overarching principle of movement, where breath, mobility, alignment, and control are integrated to optimize your performance. At Polestar Pilates, students are taught the science of movement, how to assess and design the best movement interventions for their clients. Are you ready to move? Find a Polestar Pilates graduate near you. Go to the Polestar Pilates website, click on Find Your Graduate, and search for a professional in your area. If you're ready to begin your own training, go to the Polestar Pilates website, choose your course, and use the code Dr. Brent. The code is DRBRENT to receive 10% off your tuition. And now, my conversation with my mentor, friend, and colleague, Dr. Nancy Bill. And today, I am so honored to have Dr. Nancy Bill, my friend, my mentor, the one who talked me into getting a PhD some 25 years ago, and also that sort of turned me on to music medicine and working with the theme of today, which is focal dystonias, and particularly focal dystonias with musicians. Nancy, it's so good to have you on this podcast. So thank you for joining me.
I feel honored.
Well, I'm always honored around you. And you know what's so impressive to me is you've never really ever slowed down. Like, I remember thinking, like, is there something wrong with me? I can't quite keep up with Dr. Bill in everything that you do. You somehow have magic to be able to touch so many different things. And you, of course, were the program director at UC San Francisco when I was in school in 88, 89. And you've continued to do research. You've continued to be an editor for the Journal of Performing Arts Medicine. You continue to have roles with the APTA, but you've just been a great role model always. So I really appreciate you. And I guarantee you I would not have a PhD if it wasn't for you, for sure.
Well, you're a wonderful addition to the profession yourself, so you should be proud.
Well, thank you. Hopefully I do you well. You know, one of the things that we look at in this particular podcast is education, patient education. And we're seeing now statistics that are showing us that education combined with successful movement experiences exponentially increases the likelihood of a positive outcome with our patients and people getting better. And you've always been such an incredible educator and able to sort of take the fear of some of the science out, the fear of the big words that a lot of our patients, they hear it and it's scary to them. You know, I think even in my own body, in my own injuries, my own pathologies, right? Even as much as I know about it, and it's like I specialize in chronic low back pain. And I just had back surgery a month ago and it scared the pee out of me. I mean, I was scared, you know, as much as I know, and I've seen this surgery 20, 30 times, I still was scared. So I can't imagine what our patients and clients feel when they get these diagnoses that they really don't understand. And, you know, it's like I've had physicians say things like, you know, that's the worst disc herniation I've ever seen. It's amazing you could walk, or you're a millimeter away from being paralyzed. And we create sometimes in the healthcare system such a fear. So today what I want to do is I want to just discuss what you've done as one of your life works is the science, the research, the education of focal dystonia musicians. And over the years, you have sent me probably 4 or 5 people that were in Miami or Florida that had been diagnosed with focal dystonia. And for any of our listeners that know somebody, it's a small number. I think I was looking at something like 0.02 to 0.08 of fine motor musicians that have a risk of such a thing as focal dystonia. And I've looked through a number of studies just to get ready for today, but you did one of the first experiments that looked at a possible cause of the focal dystonia with rapid fine motor movement. And once they start having an injury, if they keep playing through that injury, they're likely to smudge. And smudge is an important word. It actually is a medical word, isn't it? But to smear or to change the firing pattern or degrade the firing pattern in the motor cortex. So take it away. How did you get interested in it? Why focal dystonia? I mean, you've been around the globe a number of times. Tell us about it.
So I think I've been incredibly fortunate in my career in the profession of physical therapy, and particularly my opportunity to work at UCSF. UCSF has an incredible number of gifted scientists who are willing to work with part of the team and include a clinician on the team. And while I was chair at UCSF, Peter Oswald from UCSF had decided we should start a health program for performing artists. I had several faculty that I thought would be great consultants for this performance group, but no one was interested. I play the piano, but I'm not gifted. And I've played the piano all my life, with the symphonic band in high school and with the dance band, that kind of thing. But I would never be a performing artist. So I agreed to be the consultant and had the opportunity to work with psychiatrists and neurologists and occupational medicine docs to really understand what were the common healthcare problems for performing artists. And the kind of keynote for why we were all frustrated is when we would see a patient with focal hand dystonia, we were more challenged by how to remediate the problem and get patients back to performance. In that period of time, we learned a lot about what was the psychological part of dystonia, and for many years, focal hand dystonia in musicians in particular was considered psychological. They couldn't find any anatomical deficits. They couldn't really find a good disease, if you will, to attach to this focal hand dystonia. So I introduced myself to a neuroscientist named Michael Merzenich, and I call him the father of plasticity. And in those days, we were just really recognizing that the brain was as adaptable as it really is. Mike's concentration had been on hearing, and he developed the first cochlear implant for patients who were deaf. So when I talked to him about the problem, he said, I just want to see one of those patients. And I guess he expected to find somebody who had clear, obvious anatomical defects that would explain their movement problem. And I said, these patients are totally normal. Every other thing about them is working fine. There is something about the repetition of the instrument that they perform under a fair amount of stress. As you know, the higher you get in performance, the more stress is associated with that. So Mike agreed to let me set up an experiment in his lab, really training primates to do a repetitive task. And it happened to be opening and closing a handpiece. And they had to open and close the handpiece in order to get their food. So I would have to go in at 3 o'clock in the morning and train these monkeys to perform this task because they're awake kind of at night and they sleep during the day. So the time to really find them active is, early. So we trained these monkeys, and every monkey has its own personality, interestingly enough, just like your pets. And some of the monkeys were driven to really work as hard and get as much food as they could as fast as possible. And other monkeys said, you know what? You're going to feed me anyway, so I'll do a few little repetitions here, but I'm not going to kill myself to these repetitions. So we had a series of primates that developed a movement dysfunction, and then we went in and mapped their brain. And mapping a brain takes 5 days, 24 hours. You've got to have a team. You've got to have, the animal is well kept and well cared for during that time. And you actually map what the sensory cortex, and our question was mapping the sensory cortex, but you can also map the motor cortex. We focused on mapping the sensory cortex because we thought the problem was an input problem rather than focusing on the output. So sensory drives motor. Motor really has sensory outcomes too, like proprioception, but really motor is an output, it's not an input. So we trained these monkeys and we analyzed the data, and Dr. Merzenich said to me, you guys didn't map correctly. You've obviously made a mistake. There is no way that sensory cortex can look so bad in terms of the receptive fields, where it was located, how big the receptive fields were, where they were on the hand, where they were supposed to be. And I said, well, Mike, maybe you need to come in to the operating room and do some mapping yourself. So that our team is doing a good job. So Dr. Merzenich came in and he did a couple of points and mapped the part of the cortex, and he goes, this is amazing. I've never seen anything quite this disorganized.
And just for everybody to understand, when we talk about like the sensory cortex and motor cortex, when it's mapped out, we can see how big the hand and the lips are where we have the highest sensory. And so that's what you were looking at, because the sensory of our hands and like our lips have a higher volume of the brain that they cover in their sensory processing. But what you were seeing was, instead of seeing like 5 fingers that you were seeing, what did it look like when you mapped out the sensory on it? It was like they started looking like they were together or smudged or covering
Correct.
more, right?
So when a map is precise, like the lips and the hand, the receptive fields, when I touch a place on your hand, for example, it activates a neuron in your brain, and the receptive field of that neuron is very small. And so it's very dense, so that you have the fine sensation, particularly in your fingertips and in the palm of your hand. And when we map that, those small receptive fields have become very large. They not only were so large that they were not just on one finger, but they were across multiple fingers. And some of them were actually across the palm of the hand and the dorsum of the hand, or the top of the hand. And then some of those receptive fields actually moved and were documented on the face. So the face also has relatively small receptive fields, but the face is
I had a case that you sent me that was a trumpet player, and his accident was somebody had bumped, like there had been like a brawl or something at the bar that he was playing at, and the trumpet bumped into his mouth, and he had a pretty severe injury, required a little plastic surgery on his lip. But he'd get a dystonia on his hand when he would go up in his armature. So it's like instead, like he couldn't get the rhythm of the fingers. He'd go up, and all of a sudden his fingers were here, and he'd have to lift his elbow up to get his finger down onto the key. Before we go further on this, let's share a couple cases of what a focal dystonia even looks like, so that people are understanding what we're seeing. Then all of a sudden, this idea of what's happening in the sensory cortex starts to make a lot more sense. What are some cases that stand out for you in your history with patients with focal dystonia, especially musicians?
But before we do that, let's just define dystonia.
Okay.
So dystonia is involuntary movements that occur when someone uses a particular body part or they perform a particular task. And these movements are interrupting what we call coordinated movement on your instrument or performing your task. So it turns out that even though people say, I've never seen a patient with dystonia, I don't know what it is, it turns out it's the third most common movement disorder among the different movement disorders like spasticity.
Do tics fall into that category at all when somebody does an involuntary movement or you get anxious? Is that considered a dystonia?
No, tics are not considered dystonia because they are not really associated with the performance of a particular part or with a target task. They're different questions about what parts of the brain are involved, but for most movement disorders, multiplicity of parts of your brain are really involved in performing the task. So even though we may talk about sensory, there also is remapping of the motor cortex, probably also the thalamus and also the cerebellum. So it's not just one part of your brain. We just happen to look at the sensory part.
So there needs to be an intentional task that has that abnormal movement pattern with the task.
Right.
Yeah.
But the patients who present are desperate. The patients who develop this focal dystonia of the hand, particularly musicians, this is their profession. This is their life. And they've enjoyed playing. They've been beautiful at performance. And all of a sudden, their hand doesn't work. We'll just use the hand for the moment. But their hand doesn't work. So they put it on the piano, and instead of being able to press down on the key, the finger extends and goes away from the key, and they can't quite bring it down. And if they do get it down, it gets stuck on the key, and then they can't get it up. So you can see that it's either stuck in extension or stuck in, bending, but it's not moving in a coordinated way, which they'd always been able to do. So they are desperate because now they can't perform their task. They have gone to the doctor, and in the most cases, a person who develops a movement disorder like dystonia is not easily diagnosed by the physician. And they say, oh, you're just anxious, you're just stressed, I'm sure, just take a little more rest.
Performance anxiety. Yeah.
Right, everything's going to be fine. And that it takes a while, and many people have surgery to try to, quote, fix the fingers so they'll work better. But it doesn't have any positive effect.
Right.
In fact, it's got a negative effect on the movement dysfunction. But I think what is most important here is that there is a psychological element. The dystonia doesn't develop when you're not practicing and repeating and playing in all kinds of performance day and night, not getting enough sleep, not getting good nutrition, not getting enough exercise. It really is a total picture. It's a comprehensive look at what is your lifestyle, what is that you are doing that's leading to this high level of repetition that is helping reorganize your brain in a negative way. So you can't just treat, even though I'm going to talk about, the approach that we use, which is a behavioral input rather than Botox. You still have to have everyone look at their lifestyle and develop what I call prepare the brain for learning and retraining. And that is to have a healthy lifestyle and recognize that the more dysfunctional your hand becomes, the more depressed you become. And the more worried you are about your future, and financially you're worried about your stability economically. So by the time patients finally get a diagnosis, they're pretty depressed and concerned and feel like everything they've tried so far hasn't been able to be successful. But what is interesting is that here is a motor dysfunction that had also been associated with psychological disorder. And then we map and show that the sensory part of your brain has been totally remapped. And I had the opportunity to present our data at the Society for Neuroscience with a panel of others, including neuroscientists and physicians who were neurologists working with dystonia patients. And at the end of this panel, we were interviewed by a journalist who wanted to talk about, is this a paradigm shift in trying to understand focal dystonia? And a neurologist who's very well known, they said, what is your next line of research to this physician? And he said, I'm going to prove Nancy Bill is wrong. And I was so offended by that statement, but I should have been flattered that the evidence that we had provided really began an evidence, to change a paradigm shift.
Yeah.
And recognize that there was this possibility that there was some abnormal mapping, that it was learned dysfunction, not a congenital defect, not a disease, not a progressive impairment that was going to, compromise somebody forever, but that the brain had the potential to really retrain. And it was exciting to really be able to talk to patients about the behavioral aspects of recovery. And I was just reading an article in preparation for our discussion today, and it was a review on the treatment of focal dystonia. And the first thing they spent 90% of the paper on was Botox. And they did admit that there was sometimes some pain, that there was definitely some weakness, and that it didn't work for everyone, and that some people, did well with Botox and other people not so well. And then they only had maybe one page on behavioral treatment of focal dystonia. And the article is written in 2022. So, it's just a couple of years ago, and I am just shocked about that.
I did look at. I was also looking at systematic review today, and I pulled up some summaries on it. But it did have. It had all of the medical treatments first, and then it showed psychological rehabilitation strategies with a cognitive behavior change. And then talking about enhanced body awareness and resilience against performance pressure, suggestion, the psychological aspect of it. But it really didn't go into, it went more into prevention and just the medical. So again, thinking of, It had hundreds of studies that it had looked at, and it still was not really doing that. Now, I love what you're doing, because even in the early days of this, I already knew that you were thinking of how we can prevent it and how we treat it, and it's multifaceted. It's belief, it's the performance anxiety, it's the amount of practice hours. So if you remember, this is back in like 93, I think. I went to Salzburg, Austria, like 3 years in a row, and we had the rector of the program there was willing to let us do some information gathering. And what we had looked at was a couple different things. We were looking at things like neural tension and symptomatic neural tension, and particularly in the string player. So if you think about the life of a musician, you're playing in high school and you're an elite musician, and you get lucky and you get to go to this incredible institution where they go from playing 3-4 hours a day to 8 hours a day plus.
Correct.
Right? And what we found that was interesting, and this again looks at more like what's the behavior of these individuals, is we categorize them into neural tension of the upper extremity with symptoms, neural tension of the upper extremity without symptoms, and then no neural tension and no symptoms. And what we found was, when we started looking at lifestyle, was those that had no symptoms and no neural tension were the ones that were also swimming or doing yoga or involved in something usually outdoors, we found in a lot of their behaviors. And also in their interviews, they seemed to be a lot less stressed with the anxiety of being able to perform. So even in the group that had positive neural tension but did not have any symptoms yet, they had increased anxiety and fear of not being able to perform at the level they needed to perform in the Mozart TAM. So I think we could look at this idea of, obviously prevention is our best tool, like in the music schools, in the music teachers of how to have quality of life that can balance things so that they don't go into the kind of stress you created with the monkeys, where what is the drive behind that individual? Why do some of these people have it? I remember one case you sent me. He was a dentist.
I remember.
Do you remember?
I do.
And this was a very interesting case because he was ready to retire. I mean, he was so frustrated. And he was young. He was in his mid-30s. So, he only practiced 10 years, 12 years. And he was afraid to practice because if you went in the mouth and the mouth was facing up like it would be, if he was using his tool to be able to scrape or do fine motor movement with his right hand, he would start having weird movements or jerks or things that he was afraid he would hurt his patients. So I had an intern lay on my table and I had him bring his instruments and had him work with him so I could see what he did. Then I took a pelvis, the bone of a pelvis, and I painted, on the pelvis. And I told him I wanted him to scrape the paint off of the pelvis bone. He had no problems. He was fine taking the paint off of the pelvic bone. But as soon as the mouth was there, live mouth, he had the dystonia.
What's interesting about that, Brent, is that I will tell you the most common personality characteristic of a patient who develops a dystonia, particularly a musician, is perfectionism. That the average musician is a perfectionist. And there was a recent study showing that musicians were more perfectionists than physicians.
I saw that. I saw that study.
And that's kind of fascinating, right? So that's number one. And number two is they are type A personalities. They're really on top of it. Everything has to be done right now. They're kind of impatient. And they recognize that they have those qualities. And so part of setting the foundation for retraining is to recognize that you have these features.
Personality traits. Yeah.
And I have to tell you that, I don't know if you remember, that I developed a dystonia of my thumb. And we had collected all of our data. I had entered it into my computer. I was really staying up late at night to get all the data in. And then San Francisco had a huge storm, and there was a leak in the ceiling of the building where we were, and the water came down on my computer and totally crashed my computer. So I was going to have to redo all the data for entering in the computer. So the other common profession that develops this dystonia are people who are data entry people and software programmers because they're on the computer with that fine motor repetitive movement. And I had subluxed my thumbs, both of my thumbs, skiing when I was 21. And so I was on my computer trying to re-enter all this data and develop dystonia of my right thumb. And I had to do the same thing everybody else. I knew exactly what caused it. I knew exactly what I shouldn't be doing. But, it's hard to change the drive that's innate within people to do things right and get it done. But I had to go through all that retraining myself. So I have to tell you that is important for people to understand that I've been there myself, that I do know that you can retrain, and that's the beginning for me to start them on behavioral retraining.
I love that.
And that's not only the relaxing or, the example you gave is you changed the environment where he was performing the task that caused the dystonia, and he could do it normally. And similarly, if you put somebody, like I had a saxophone player who had a dystonia, and he was very frustrated because he was very good and he was in a jazz group in San Francisco. And I had him lie on his back and I had him put the saxophone on his abdomen.
Change the orientation.
And he was able to play like he didn't ever have the dystonia. And he was absolutely shocked that he felt that his hand was so coordinated and controlled. And so you got to put people in this unusual environment and maybe their whole orientation with gravity. I had another patient with a cervical dystonia, and I put her on the inversion traction unit, and her cervical dystonia was so bad it also caused a phonetic dystonia. And when I held her upside down, maybe at 45 degrees, and I gave her a book, and I moved the tilt table up and down, and she was able to read like she never had a dystonia, and her neck was still. And her father was standing there and saying, "Oh my gosh, I can't believe this could be happening." So you have to really, part of your treatment is to really go through that evaluation.
Find a foreign environment for them.
Yes, that they
Yeah.
can begin to retrain. It's not like, I say to them, look, I don't expect you to go back on stage and play your saxophone while you're lying on your back. That's not the purpose. This is a way you have to really improve the interface between your hand and that target instrument, whatever it is. And that begins your retraining format. And a
Yeah.
lot of imagery, when you imagine, I ask people to go back in time when they could perform and they didn't have the dystonia. And I tell you, some people have to go back to when they were like 6 or 7 years old to really realize that, this movement dysfunction has been coming on slowly for a lot longer than they thought. Finally kind of broke the bank. But, you got to have people go back and say,
I think this is so common. I think we act like it's not that common, but the reality is, like, even for myself, today I go to physical therapy for the first time, and we went back because if you think about it, even in my history, you followed where I've had both hips replaced. I had hip surgery 30 years ago. I broke my neck at 47, and I'm a master at compensation because I have to perform. I have to perform every day I go on stage, every time I'm in front of a group. And so these last couple of years have been very hard for me to overcome the limitations that I've acquired. So today with Brian, he's like, no, I just want you to stand on one leg and resist me. And I couldn't do it. And I tried to do it on the other leg and I couldn't do it. And he made a comment. He said, the most elite athletes have the most severe neurological compensation patterns for their injuries because the show must go on. And then I thought, that's exactly what we're talking about today with musicians and ballet dancers, where it's not so much that it's an athletic performance, it is that the show must go on.
What's interesting about that, Brent, is that you have natural compensation that everybody kind of does to account for, an injury or recovery or whatever. And yet the same people don't believe that the brain is adaptable and plastic. Right. And in order to really retrain, people say, well, how many times do I have to do it? And I have to say, I don't know exactly how many repetitions you need to really improve and normalize the processing of your brain. But I know you need to do it, and it needs to be fun. You need to do it regularly. You need to do it with someone else. You need to really challenge making decisions about sensory inputs. And you need to do it enough so you really retrain the brain. And we have shown that in people, particularly musicians, that when we put them through a retraining program, that they do remap their brains. And their brain looks more like normal, and then they're back to performing the task.
Is there anybody that doubts neuroplasticity today in healthcare? Do we still have?
I think physicians and patients have not quite gotten there yet. Yeah, I believe there's a little plasticity, a doctor will say, but you can't, you've had a stroke, there's no way that you can be normal again, or your hand, you've got dystonia, and they tell them that, we can learn to manage it with medication, some relaxants and other kinds of, anxiety medication and the Botox. But they really don't want to focus on, it takes time, effort, and commitment to really retrain your brain, and you have to believe that it'll work. And I have found by now I do a lot more on telehealth with patients with dystonia all over the world because they don't live near me. And I encourage them to find somebody to work with, whether it's a spouse, a friend, or somebody else who has dystonia. And I've been lucky to really hook some people up together to work together.
You're a matchmaker.
And you know what? They're getting better because they've got somebody who understands what the problem is and who's willing to work with them. And, one may be the therapist one time and the other one is the patient, and then they reverse their roles. But
love it. And they can do it remotely, right? They can be just like you and I are right now,
correct,
coaching each other and teaching
correct,
each other.
But you kind of have to be comfortable with that. And, I didn't think that I would be necessarily comfortable with that. I always thought it was easier to be one-on-one with the patient. But I think you can make significant difference by even working with someone on Zoom or on the phone. But the other important piece is they say, well, how long will it take for me to get better? Is it a week? Is it 2 weeks or whatever? And I tell the story. I had one patient who was a violinist. The first thing I asked them to do is to mentally practice, but not to physically practice, so they can maintain their skill. But he was able to mentally practice. He could quit playing, and his wife was working, so he was comfortable economically, and he got better in a month. And he worked at it every day, very hard. He was very committed. And I saw him, maybe over 5 years, I saw him repetitively, and he was still doing well. So I had another patient who was a pianist, and she was very good. She was a teacher and a performer. And I had her doing Braille because she had terrible sensory discrimination problems. And I said, here's something you can do at home alone.
What a great idea. Yeah.
And I had her get a Braille book, and I had Braille book 1, 2, and 3. And most of my patients never got out of book 1, right? Because learning to read Braille, if you're not
needing it,
you're not blind, then it's hard. But anyway, my patient did the Braille. She was doing great. She was in book 3, and she just kept doing Braille, and life was good. And then she said, look, I've been doing Braille for 5 years now. I think I've had enough. So she quit doing Braille, and guess what? The dystonia kind of returned to some extent, and I said, why did you stop doing Braille? Well, because I'd done it a long time. I know everything. And I said, your brain needs that sensory input in order to help you continue to play as you do on the piano. So she went back to doing Braille, and her performance was back to top shape again. And she called me and said, it works.
Yeah. So let's make our number one point here. We're talking about being able to have hope if you have this diagnosis. There are people that are getting better. It is a more holistic approach. It might involve, it is going to involve a number of practitioners, but most importantly, it's education and practicing, re-educating the neuroplasticity of the system. And when we do that and we put the energy into it, we can get better without having to have all the anxiety of never being able to perform again, or I'll never be the same, or I can't do this. And we also made the point of a little bit of lifestyle change, right? We're looking at things of like, how do we manage. It'd be good to have the coaching to manage anxiety, to manage depression, to manage fear. To me, fear is one of the biggest deterrents of successful movement. I often talk about mobility challenges, and I talk, is it a strategic challenge or is it really a structural challenge? And I would tend to say, just in my clinical bias, that it's closer to 60% of what I see that are strategically restricted in their movement, with fear, that have changed their motor programming of how they move and how they move through life. You think of it, it's hard work. It's like chronic. It's like a chronic pain kind of thing. After a while, it just becomes hardwired, and it is what it is. And all these things stimulate this behavior, whatever it is. We have to go back and repattern and relearn and become educated and go into foreign environments. That was the beauty of the Pilates for things like low back pain. Is we could create the foreign environment to do the same movement they would have to do in standing or working, but we could decrease the load, we could manipulate the load, we could increase the repetitions to get the learning pattern going, and eventually progress them back into their activity and their function. And that to me has come from what you were doing with focal dystonia. Another thing that I was looking at, I pulled something up, and it was just defining different types of focal dystonias, particularly musicians, where it was the one we've been talking about, which is usually hand with fine motor skill musicians, also had amateur, and it also had lower limb dystonia. And I haven't seen this, maybe you have, but somebody with a lower extremity focal dystonia. So they had no problem with their speech, but as soon as they started singing in different ranges, they would get some kind of vocal cord dystonia.
Right. Called dysphonia.
Dysphonia.
Yes. So I've seen several drummers, and again, it's mostly the foot, playing the drum. And again, that's very repetitive, and depending on the kind of music you play. And it's tough because they're usually a single drummer for most of the small groups. And so for them not to perform, then the whole group can't perform. So there's a lot of pressure there. But there's also runner's dystonia, and it's been surprising to see how many physicians who run early in the morning before they go to the hospital, and they're running at night, it's still dark, and there's a lot of stress to run particularly if you're female, to run by yourself when it's dark. And most of the runners that I've seen with runner's dystonia are people who are running very religiously every morning or every night, and it's always dark.
And most of them are female, or are they male in this situation?
The ones who are running at night are mostly female, but I did have an air controller person who developed a runner's dystonia.
They don't have any stress, air controllers?
Yes, a lot of stress, as you know. And this particular fellow developed a runner's dystonia because he ran with the same intensity and perfection that he was trying to do his job. And we tried a lot of different ways to make him more functional. But it was very interesting to work with people who have a runner's dystonia, might also have Parkinson's disease. So they referred a patient from Stanford to UCSF, and the neurologist came with this patient with runner's dystonia. And I put her on the treadmill, body unweighted, and then had her run where she didn't have to worry about falling and things like that. And she clearly had freezing. And I said to the neurologist, have you worked this patient up for Parkinson's disease? And she said, no, I didn't really think about that. I thought it was pretty much runner's dystonia. So they started treating her with dopamine, and her running got much better. And then she followed some of the other exercises we recommend with dual tasking, cognitive learning, and fine motor activities. As you know, I push people to do dual tasking as part of their retraining. And it really is helpful, and it's important because it helps.
Explain that a little bit, dual tasking.
So one of the things with runner's dystonia, for example, is I would have them start walking on the treadmill, body unweighted, so they didn't fall. And then I would play catch with them. We'd be throwing the balls back and forth, or we'd be solving lateral puzzles, or, we'd have a particular story to tell, and then we had to finish the story. So while they were exercising, they were doing something that was really cognitive and attentive oriented. And that really does seem to help. But I can't emphasize enough about mental imagery. And there's a recent study that I read that a patient, for example, who has a movement problem will do better if they visually observe someone doing a task, for example, and do mental imagery, and do regular traditional rehab to increase strength, range of motion, and patterns of movement than just doing regular therapy without the visual observation, without the imagery. So imagery is critically important.
We use it in performance with sports. I mean, that's, the whole idea of the elite athletes is watching the professional do it.
Right.
Imagining themselves doing it like the professional, and then practicing doing it.
But that also applies in recovering from a stroke, recovering from a dystonia, recovering.
It's just the way the nervous system learns, you think?
Yes,
the whole
I do
system?
think that. And, I talked to a friend who is an oncologist at UCSF. And, I've been working with him for over 20 years, and he had Parkinson's disease. And when I met him 20 years earlier, he thought his life was over. And we began to work on some of these tasks, mental imagery and dual tasking, and I had him join a group of patients in the morning, and we were working out and playing games and having a lot of fun. And here he is 20 years later, he's 72, and he's still a full-time faculty member, and he said, I just wanted to call you and tell you how grateful I am for your changing my life.
How frequently has he needed to increase his synthetic dopamine?
Well, there are people like Dr. Merzenich, who was my mentor. He believes if a patient has an early diagnosis of Parkinson's, that you delay giving him dopamine and create all the activities that are learning-based to upregulate dopamine, because you need dopamine to learn.
Yeah.
And he feels that if you really push all the activities that upregulate dopamine, that those people will have to go on dopamine later, and it won't be as heavy a dose. And also there's a new IV delivery of dopamine. I don't know if you've heard about that. And my friend, who's the oncologist, said, I just wanted to tell you that with this 24-hour release, I'm taking less dopamine, and it's evenly distributed across the day, and I don't have the highs and lows anymore either.
Right, the freezing in the afternoon.
So that's, there are times when medication can be helpful with a movement disorder. It depends on what it is. But I think that the most challenging thing is to convince the patient they have it within themselves to get better. And, right-left confusion is another thing we see in patients with dystonia. And there are games to play for right-left confusion. You can get online on your phone and work on these programs. So I think there's just a lot we can do on our own if we're disciplined to do it.
Yeah.
And getting people to do things at home alone is really a challenge. So I try to encourage people to bring a friend or, have their spouses there and talk about how they can work together and make it fun and both learn.
Yeah.
I have people gambling with Braille cards, for example, and tell, guys are especially terrible unless they're bidding money. They wouldn't even bother to learn Braille. So there's a lot of fun things you can do. And as Mike says, when you make it fun, people are willing to do it.
That was a big part of our, I know it's true with Parkinson's. I know that the more that we could get them to laugh, it was like their movement improved a lot. And so we would play really silly music and old music that they would start wanting to sing. And, they were also part of an art program, the same group that went over to a local Jewish synagogue and would do art projects. And they'd bring the art projects in to show each other. And they were hilarious. Like, you'd see in a first grade class, some of them were so funny and we just would laugh.
Yes. And it's important, even as professionals, we're not always really good at treating ourselves. And I don't know if you knew this, but I was skiing with Marcia Melnick, who you might remember.
Yeah.
And she fell down and broke both of her arms. And she, as you know, had her PhD in neuroscience, and so she was very much involved in the field. But when it's yourself, and I started talking to her about imagery and what she needed to do, and I gave her a bone stimulator that I had purchased myself, and she said, "Oh, that won't make it." I said, "You're going to use it anyway." And she was back. And use it. She was actually back in dancing with her Parkinson's patients because she ran a group for patients with Parkinson's disease in Squim.
Why is it so hard for us to treat ourselves as practitioners?
I know. but it works.
Hard. It does work, and that's why I insisted, and it's like I told everybody, the doctor was pretty emphatic about me not doing any rehabilitation for the first 6 weeks after having the back surgery. And 6 weeks of me not moving is like a death sentence. It's like I wanted to go out and lift the 50-pound bag of dog food, and I wanted to, get the weeds out of the garden and, drive. And I did some of these things. I don't want my doctor to know, but I did do some of them. There's something I wanted to finish up with, Nancy, and something I've been thinking a lot about. This is sort of in the idea of alignment, and we talk about alignment of body, mind, and spirit, and how when we have that alignment, we're most likely to have joy. We're most likely to be present in our life. We're not wishing we had done something better in the past or being afraid of something in the future. And one of the words that keeps coming up in the psychology literature for me is internal locus of control.
Yeah, okay.
And this is what you're talking about. So to our guests that are listening, it's an internal locus of control that we've gotten away from. We live in a world that is very focused on external locus of control. Fix me, give me the medicine, give me the surgery, make it happen, manipulate me, stick needles in me, fix me, right?
Yeah.
And we're not willing, and I'm included. I mean, this is just our culture today, that we have so many of us that want that quick fix. Give me the magic pill. I don't want to exercise. Just give me a shot that makes me lose weight.
Correct.
Just do it, right? And we don't realize the consequences that if we don't do our best to change the behavior and we don't take control of our behavior, that, then we really are not going to have the successful outcome that we dream of or that we hope for. And I think that we just need to continue to educate people to help them. It's like even internal feedback. What are you feeling when you do this? What are you observing when you do this? Carol Davis's work of getting patients to tell their story so that they can hear themselves. And sometimes their stories don't line up with their reality, right? So we look at that alignment is, what are you afraid of? What are you believing that is going to happen? And when they can express it, especially with something that is career threatening, especially something with perfectionists like elite musicians, this is a very important conversation. And you have this conversation with all of your musicians. And it's like, how do they take responsibility, get educated, and take responsibility? Being educated alone isn't enough. is not enough. It has to be education on pain combined with successful movement experiences. And when those two go together, you're going to have the best outcome. But the person still has to move.
Correct.
Right? They have to do the exercise and the hard work to re-educate their system.
But I'd like to just close with one other thing. I think it's helpful if a patient has a physician that reinforces this behavioral approach. And often the physician doesn't give that positive feedback. And I think I told you that my husband, by error, ran over my foot with a car.
You did.
And I ended up by having the metatarsal fracture that needed surgery. And I was told 12 weeks non-weight bearing on a scooter. And I said to myself at 83, for me to be non-weight bearing and not doing anything but on a scooter for 12 weeks is a death call. So I learned how to take my boot off, drive my car, and go to the gym and be on a recumbent bike and get my heart rate up and exercise. And when I went back, and he said, I am really surprised to see such good healing. And I said, I hate to tell you this, but I didn't just sit around on my scooter.
I broke all the rules.
Yes.
Well, when I talk to surgeons about that, I mean, this is partly our fault too, right, as physical therapists. I think that, the reason why, and a lot of my really good friends in spine surgery are like, I don't trust you guys. It's like I've had so many screw-ups with when I start to trust you and I send somebody to you a week post-surgery, and then, they come back with failed hardware or you did something dumb with them. And it's like, if you guys could get your act together, we would trust you to start doing graded load a lot earlier, both on the nervous system and on the structural system. And so I've been lucky to have some surgeons that trusted me. Like I would go into the surgeries and watch the surgeries and ask all the questions about the surgery. I wasn't trying to promote myself. I wasn't trying to impress them. I wanted to know what they're doing and what their belief was on tissue healing, adaptation. And I wanted to understand, how can I as a physical therapist understand what those structural tissues are going to do in their response and their adaptation to load as part of the rehabilitation. And then what you just said is, we know now, like you have a fractured humerus without displacement, we want the weight of the arm on that fracture.
Correct.
We know that the connective tissue around the arm is going to speed up the healing process of that bone versus complete immobilization. We know that with the lower extremities. We know that there is a certain amount of tensile strength inside the bone because of the periosteum. And so we need to be able to respect that to speed up the healing of it. Well, it has been so fun, and you and I could talk for hours, and we can come back with another hot topic of Dr. Nancy Bill in a future podcast if you like. You just are a dear mentor of mine and dear friend, and can't thank you enough.
I still think I need to thank you for mentoring my daughter. Remember, she volunteered in your clinic before she got into PT school.
Yeah.
So I now have a daughter, a niece, and a granddaughter who all have gone into physical therapy.
Oh, that's so awesome.
There we go.
All right.
So
well, listen,
thank you for including me, and I look forward to seeing you at CSM, huh?
We'll see you there for sure.
All right.
Love you, Nancy. Thank you so much.
Love you. Bye-bye.
Thank you for joining the Live Aligned podcast. If you like what you hear, please let us know by leaving a review on your favorite platform. If you have comments or questions, please leave me a message at drbrentanderson.com. You can follow me on Instagram at drbrentpt. To take a deeper dive into the science of movement, check out my new book, Principles of Movement, available on Amazon. Live Aligned podcast is produced and edited by Gabe Anderson. Music and sound designed by Delver. Special thanks to my team, Elizabeth Jimenez, Melissa Pereda, Cesar Maya, Gary Bentz, and Charlie Zuckerman. I also want to thank the team at Polestar Pilates for sponsoring and supporting us with technology, marketing, strategy, and much, much more. Thanks again for listening. Live aligned and be kind.